So on behalf of our Seattle Children's CRMO clinical program, I want to welcome you all to be here today. We're so glad the weather cooperates. Unlike last time, we had some storm the right night before. And also, we have the online people who can join us as well. My name is Zhao. I'm the director of the program. And Ava Klein is our program coordinator, who's going to come here and show you all the details of today's agenda. But I just want you all to join me to give thanks to Ava. She's really the true hero behind all this event, that she has put all the things together and for her masterful planning. So let's give a round of applause to her. Thank you, Ava. I also want to thank all of our speakers today, including Dr. Jenna Thomason, if you want to wave hands to others. She's our adult rheumatologist colleague from University of Washington at Harborview, and Dr. Tom Jinguji, if you want to wave your hand, who is the medical director of our sports medicine at Seattle Children's, and also Dr. Fazana Nurzaman from Stony Brook in New York. She recorded the video, so she won't be here in person. And also, we have our colleagues, Susan Thornhill, right, Susan, and Nancy Hartwick, and Paula. I think Lisa may be here as well. They are qualitative researcher as well as group facilitator. Susan has conducted the research project with me and Dr. Oliver, and she flew all the way from California. So thank you for bringing the sunshine to our conference. And also, I want to thank our volunteers, our students, and also the Sandpoint Learning Center. So without their help in this conference, it won't happen. And also Katie, who is going to join us at lunch, who is the family support expert. So the goal of this conference is really to share some of the knowledge and from our speakers, and also I'll provide some of the research update. And then Susan and her colleagues are going to help and to facilitate some of the group discussion among you all. So I just want you all to connect with each other and really build a stronger community among all of us. I saw some of the parents here, their kids are already grown-ups. Some are in the NIH doing amazing research. I'm just really proud of everything that they're doing and continue to guide the other families as well during their journey. So just want to thank you all for coming and enjoy the program. So I'm going to turn it to Ava.
All right, welcome everybody. So happy to see you all here, and those online, hello as well. I don't know where the camera is, but hello as well. So this is, we've now been doing this for 3 years. So this is the third year of the CRMO program, being a program in and of itself within the Seattle Children's Rheumatology division, and it's a really amazing that we get to do this. As you can see, we've got a photo from our last conference, all the people there. Just it's a pretty special thing that we get to do. Not every department in the hospital gets to do this, so I'm really glad that you all are here and we get to connect like this. The Sandpoint Learning Center staff are sitting at their desk up front, and they can help you find anything you need. They know this building like the back of their hand, and then we have our UW volunteers who are here to help as well. We're welcoming back, as Dan said, Susan and Nancy and Paula as well. And then we have Linda. Hi, Linda. Linda is in the back there. She works in our rheumatology department as well, but she's an amateur photographer, and she is volunteered her services to us. She is taking photos. We might use them for presentations like this one. You're allowed to not want your photo taken. That's totally fine. If you don't sign a waiver and return it to us, we will not share your photo anywhere. So bathrooms are on both sides of the main lobby here. There are also individual bathrooms if you continue along back on the left side here. Breakout rooms will be assigned a little bit later. We want to make sure that we have everyone captured, so when we come back from our break, I will let you know where the breakout rooms are. I'm going to run through our agenda here so we all know what to expect. First, we've got Dr. Jenna Thomason, who is, as Dan said, an adult rheumatologist. She'll be presenting about the transition from care at Seattle Children's. Once your child reaches a certain age, we can't see them anymore, so we hand off to Jenna and the other adult rheumatologists in the area. So she'll be speaking about that, and then we'll have a question and answer. So if you have any questions about a transition, if you're going to be transitioning soon, if your child is transitioning soon, or maybe not even soon and you have questions about it, feel free to ask those. Then Dr. Tom Jinguji is going to be talking about sports and CRMO, and we'll have a Q&A there as well. And then we'll have our research portion where Dan, Ian, I don't know if Ian is going to speak, but I'm going to point him out. He's in the back corner there. He's our new clinical research coordinator for the CRMO program. So some of you may have met him, some of you may have not, but he is here today if you want to say hi. So we'll have a little presentation, we'll watch a video, and then some Q&A there as well. All you virtual folks, if you have questions for the Q&A, feel free to put those in the chat, and we have some volunteers who will read those out to our presenters, so feel free to ask those questions in the chat. After our presentation, we'll have a little break. It's a lot of sitting and listening, so that's where you can get up, stretch your legs, have another snack, and then we'll come back in here and we'll do the breakouts. Parents and caregivers will be assigned breakout rooms. We have 2 downstairs and 2 upstairs. And then in the auditorium, if you're not a parent or caregiver, we're going to hang out. We've got some games. We've got a collage that we're going to make. We're just going to have a good time in here while the parents do the boring stuff. Just kidding. It's very important. It's not boring at all. And then at noon, in person, we're going to have lunch. We'll have some food from Free Lard Tamales. They're going to be here. And then virtual, we'll check in with you and we'll do your peer matching then. We don't want you to have to sit around while we're all eating. And then after lunch, for those of us in person, we'll meet back in here at 12:35. Katie will be here then. She is a family support specialist at Seattle Children's, and she helps match families together who are going through similar journeys so that they can find support in each other. And so she'll talk about her role, and then we'll match you up. And if you wanted to be matched, we have pre-matched you, and we're going to assign you your family that you can check in with. As you may have walked around a little bit, there's a lot of places to sit and just hang out. So if we're going to release you to go anywhere in the building, you can sit down here. There are couches upstairs. You can use one of the breakout rooms to just chat with this new family that you're meeting. And then if you decline matching, we're just going to hang out here in the auditorium and we'll chat as well. And then from there, it's kind of, you're released whenever you're finished chatting with each other. So there's no hard stop. You can just be done whenever you're finished with your conversation. So that is our overview of the agenda for today. We wanted to give some program updates for what we've been doing this year. We had a Kayla's Comfort 5K. Kayla's Comfort 5K. There's the starting line there. And that was a great success. We raised a lot of money that came back to our program and supported research. We had a lot of fast runners that day. It was super awesome. I was glad to see a lot of you there. We also started up an advisory board, which the hospital supports and pays families for their time to give us feedback on what we're doing. So we have 3 parents on the board and 1 young adult who is a former patient, and they advise us every quarter on what we're doing and give advice and give ideas. So that's a really cool thing that we were able to start this year. And then we're also going to be starting a quarterly newsletter. So we will send out information about what we're doing as a program. We're going to do Q&As with some of our staff, and then we'll talk about upcoming events, just so you can kind of stay plugged into what's going on with our program. For right now, here's our schedule for this year. In 2024, we're going to have more information coming soon in the newsletter, but we wanted to give you an overview of what you can expect. So as you can see there, we are in February. We're at the family conference. It's a little pixelated, but we'll get you this information in clearer detail. In May, our CRMO Warriors Guild is having a fundraiser. In July, we're going to be using Camp Corey. So many of you came to Camp CRMO this past year, which was awesome. Camp Corey provides a free week-long camp in Mount Vernon, and we are going to invite our CRMO kiddos to go attend and have fun, and Dan and I will be there volunteering. It's going to be a lot of fun. They have a lot of exciting activities that I'm sure you'll enjoy, and we'll send out more information there, but that's going to be July 21st through 25th. And then MBarC Ranch has invited us to come. That is another free event that is horse riding and ranching and hot dogs out of a chuck wagon. It sounds like it's going to be a good time. That's on Whidbey Island, so put that on your calendar if you'd like to attend. All of our families are invited for that as well. And then we have our 5K this year, sometime in October. We don't have a date or a location yet for that. And then Camp Corey has a weekend family camp, so that's for the whole family to attend over the weekend, and we'll have a lot of fun that weekend as well. So a lot coming up. Like I said, I'll share this information out, so you can put on your calendar whatever you would like. But we're really excited that we're able to have so many fun events, and we have such a wonderful community to support our kiddos. So that's all I have for us today, and I'm going to transition over to Dr. Jenna Thomason, who's going to speak about transition.
I'm Jenna Thomason. I'm an assistant professor at the University of Washington. I'm an adult rheumatologist. Thank you, Dan and Ava, and to all of you for having me here. So I'm going to talk about two things today. I'm going to talk about transitioning from pediatric to adult care, and then I'm also going to talk about how that particular topic as how it relates specifically to patients with CRMO. So there's a lot of words on this slide. So this comes from this great resource called gottransition.org. It's absolutely fantastic, and this is not just for rheumatology patients, but for all patients with chronic illness who are transitioning from pediatric to adult care. And what they say, really, with all of these slides is that transitioning to adult care is not something that just takes place at one moment in time. It's something that you're kind of getting ready for over time, like even starting at age 12. You're starting to think about how you tell your story, trying to progressively become more and more independent with your care, thinking about making your own appointments, learning about your medication regimen, starting asking your own questions of your doctor. And then as you become 18, you are the person that is legally responsible for your care. But then it actually happens. You actually transition to adult care. And at the same time, there are all of these other things that are happening in your life. You may be graduating high school, maybe going to college, maybe getting your first job, thinking about moving somewhere away from your family to go to school or do other things. You may be in relationships that may be different from prior relationships. You may be leaving this great support system that you had in your life. And depending on your situation, you may also be having to think about health insurance, something that you really never had to think about before. So that's all at the same time where you're becoming the main person in charge of your health, and it could be really, really scary. So you practice telling your story, but now you got to tell your story sometimes without the support of the person that was living that story with you the whole time. And you have to know your medications and manage your medications, know how to fill those medications and make your appointments. And also, you'll be the person sort of one-on-one discussing your care with your doctor. Also, there's some differences between pediatric and adult rheumatology practice. I love hearing all of these great sort of camps and all of these great resources for kids. I wish that we had all of those things in adult care. But when you transition to the adult realm, it's less of a family-centered interaction, more of a patient-centered interaction, more of a focus on medical concerns. Sometimes the clinic visits are shorter. Depending on where you transition, the clinic visits may be anywhere between 15 and 30 minutes long. And sometimes medications can be different. We are fortunate in that in the adult world, we have actually more medications that are approved because they have to undergo more rigorous study to be used with kids. So that is sort of one thing that changes in a positive way when you come to adult care. Unfortunately, we don't have the beautiful clinic space with the fish and the dinosaurs and all of those kind of things. It's more of an austere environment. And unfortunately, less of this just incredible support in adult care. So one positive thing that I want to say is that although I'm sort of painting this picture of adult care as being not as colorful and wonderful, we're trying to make it better for young adults who are transitioning to adult care. So this is a project that I'm doing with one of our incredible fellows. This is my research and clinical mentee, Dr. Cindy Chu. So we are trying to figure out how we can support young people better as they are transitioning to adult care. All of that information that I showed you before about sort of readiness for transition, all of that research is done on the pediatric side. And there's very little that has been done to study these young adults after they transition to adult care. So we're trying to figure out what can we do to support young people, because as I said, they're going through so many transitions at one time. So we're starting a study. We're just collecting baseline data right now, assessing confidence and independence with transition, and trying to figure out how best we can support these people, whether it's offering reproductive health care, resources, or mental health care. We are trying to figure out exactly what we can do, and this is taking place at all of our sites, so Harborview, Roosevelt, and Northwest Rheumatology Clinic. So now on to CRMO specifically in adulthood. So the truth is that CRMO is rare in adults. And I found this statistic, and I don't know if I believe it, said only about 10% of cases of CRMO onset in adulthood, and I actually think it's probably less than that. So this is a study from, or a slide that I have borrowed from Dr. Lannis and Dr. Zhao. The incidence of CRMO is increasing, and this is really, really staggering. So years ago, the incidence was much lower, or at least we thought it was much lower. Maybe we just weren't recognizing it. And now we're seeing so many more people that have this diagnosis. And so I will say that what we know as adults about CRMO, we have learned from the pediatric literature and from young adults who are actually transitioning to adult care. In the adult world, we have CRMO, and then we also have this diagnosis, which we think probably exists on a continuum with CRMO. It's this diagnosis called Sappho syndrome, and essentially what it is it is like CRMO. It shares this feature of osteitis, but these patients have a lot more happening on their skin. They often have severe acne, pustulosis, in addition to having bony lesions. And so, again, we think that these things probably exist on a continuum, but we have so much to learn, and we want to learn. So this person, this is Dr. Lennert, Alex Lennert. He is an adult rheumatologist at the University of Iowa who is very dedicated to trying to understand these diseases, these diagnoses in adulthood. This is his mentor and primary collaborator, Polly Ferguson, who is a sort of renowned expert in this condition, like Dr. Zhao. And Dr. Lennert has been awarded some funding from the NIH to study these patients over time. And so they've already started recruiting at the University of Iowa. They have about 80 patients. And pretty soon, very soon, in fact, they will be expanding to the University of Washington. So here, Hospital for Special Surgery, and the University of Pittsburgh. So what this is exactly, they're doing surveys over time, and there's a sort of specific assessment to fill out during clinical visits that ask about symptoms and physical exam findings, and then they're also getting cheek swabs, actually, so that they can look at genetic material. So this is very, very exciting. We have so much to learn, and this is a great first step in that direction. So also included in that study will be whole body MRI, and it's just part of regular clinical care, whole body MRI. And we are very fortunate that we do have whole body MRI at our center. This isn't something that we've always had. Again, we're learning, and this is something that we have been doing since end of 2021 or 2022. So yeah. So just one quick comment about treatment. What I really wanted to say on this slide is that we have the same treatment algorithm that we have learned from our pediatric colleagues, but also the adults may be a little bit different in the medications that they respond to, and we have more meds that are available to adults. So as you are sort of transitioning to adult care, there may be additional options that are available to treat this sometimes really refractory disease, and so that's one positive. So thank you all for listening. Again, this is my name, and then if you are interested in being seen by me or one of my colleagues, I put our fax number up here. Also, if you are, say, going to be moving elsewhere when you transition to adult care or prefer another clinic, you are absolutely welcome to contact Alex. He is interested in connecting with all patients with CRMO, and he will meet with you over Zoom and talk about how you might be able to be engaged in the study. He's just very, very enthusiastic about recruiting as many patients as we can so that we can learn as much as we can. And then also, for everybody, I put the Got Transition website up here as well. It's, again, just a fantastic resource, and it's never too early to start thinking about these things. So thank you all. I'll take any questions.
Yes, thank you, Jenna. If anyone has any questions, just raise your hand, and Ian here is going to come find you so you can ask them.
Yeah, of course, yeah. I will. I handed them over to Ava, so she gave me the thumbs up, so yes.
My adult son is transitioning to adult care literally right now in Maryland. And so he's found a rheumatologist, but the rheumatologist is not familiar at all with CRMO. So I mean, he got the medical records from Seattle Children's and stuff like that, and he's about to do doing an MRI right now. Is scheduled to get one so the doctor will have a baseline for where he looks like compared to what he looked like as a child. So I guess, but what's a good resource that we could point the doctor to, I guess, for finding out more information, because he literally knows nothing about CRMO at all. So.
Yeah, and I think that's probably unfortunately a common experience for a lot of people that are transitioning to adult care, because it's just such a rare disease. And like I was saying, most of what I've learned is from young people who are transitioning to adult care. There is some, there is some literature out there about looking at adults with CRMO versus kids with CRMO. But I guess probably the best place to look at this point is really in the pediatric literature. And then also sometimes when it's such a rare diagnosis, just reaching out to experts. I know I commonly reach out to Dan to help me with difficult situations. So I guess reaching out to their pediatric rheumatologist as well.
I just want to add on to what has been discussed. So the care work group, and along with patients and parents, we have generated a handout. So that is available on crmoawareness.org. And also we'll try to put those on our program website as well. And I think in the future, there should be more dedicated places for these. And it's always a good idea to carry one of those handouts when you go to see a new doctor, just in case. And Dr. Jenna Thomason and I have collaborated, so already received maybe 10 patients so far, so she's becoming a local expert from the adult rheumatology world. But one of the efforts is really educate more adult rheumatologists, because there are many more of them, about this condition, even though the adult onset is not common, but we have plenty of our patients graduating. Now we have almost 500 patients we take care of each year, right? If you think in 10 years, all of them, majority will go to adult rheumatology. Yeah.
Yeah, thank you for that question too, because I think that's really important, and we need to do a better job too of sort of educating each other in the adult world. Thank you, guys.
So our next speaker is Dr. Tom Jinguji. So he's going to talk to you about the sports participation for CRMO patients. I believe there is a different file. Okay, is this? Thank you, Tom.
Hi guys, I'm Tom Jinguji. I'm one of the orthopedics and sports docs at Seattle Children's. Dan and Ava, thank you so much for inviting me. And okay, I'm just gonna say this: Jenna's slides kick my slides. They're just incredible. And I'll be honest with you, I'll do the very best I can up here. And you guys are the experts, and I'll try to speak to an audience that's that goes from 5 up to 45 plus. So I'll do my best. Be kind to me, okay? All right. So physical activity, sports participation, and CRMO. And Dan will help me if I make too many mistakes as I'm speaking. But one of the questions we might have is, as my kid's active, as he does more stuff, and he falls, how do I figure out if this is CRMO going on, or is this going to be like a broken bone? And that's what we're focused on. But we're also going to talk a little bit about a few other things. So we'll talk about, hang on here. So we're going to talk about injuries. We're going to talk about how we can break those down into acute injuries and soft tissue injuries versus bony injuries, how to determine injury versus CRMO, and then we're going to talk about sports participation and activity in folks with CRMO. Try to be done on time too, okay. So, is physical activity okay for my son or daughter with CRMO? So, the original slide said child. So, everybody who's under 18, do you like the term like children, a child? Yeah, I'm a child. I thought that's kind of like a little bit, I don't know. So I put son or daughter, but son or daughter isn't really good either, because there's people that don't go by son or daughter. There's people that are wards of, and stuff like that. So I changed it a little bit. So is it okay for my kid? And I'm going to actually say, how about this? Is physical activity okay for me if I have CRMO? Okay? And I say yes. Some type of physical activity is really good for you, no matter what. We'll figure out activity. Activity is good for your mind. It's good for your bones. It's good for your heart, your lungs. It's good. Dan helped me with this, though. So if you have CRMO and you're just getting better, you're very, very deconditioned, Dr. Zhao and the team is going to always try to recommend physical therapy to get you going. Does everybody here know what physical therapy is? Everybody? Okay, yeah, to me, I got a thumbs up. Physical therapy is kind of like halfway between a doctor and a PE teacher. They will help you to learn to do things. Like if you have real balance problems because you're just getting started, they'll help you with balance. Most of you guys are probably a little bit in better health, but they'll get you going and make certain that you're safe and doing well, okay? But physical activity, good. Is sports participation okay for me if I have CRMO? Can I do sports? Can I do all the stuff I want to do? And I asked Dan. Dan said yes. If your chronic recurrent multifocal osteomyelitis is doing well, it's being treated and on effective meds, or is in remission. So if you're doing good, I want you to feel good about your body, move forward, do great things, and have fun. Sports is really about fun. much more than how you think you're supposed to be great at this or something. It's about fun, okay? Feeling good about it. Okay, is PE participation okay for me if I have CRMO? Should I go to PE? Yes. This is one of the things, again, this is from the program too. If you're going to do PE, we should recommend something called a 504 plan. And for you guys, I hope you don't know, have to know what this is, but a 504 plan, IEP, individual education plan. A 504 plan is something that can be put in place pretty quickly and pretty easily, and Dan can help, I can help with that, but to accommodate. If CRMO has a waxing, waning course, you're feeling good or bad, we should allow for that, right? Self-pacing. So if you're not feeling that good that day, we should let you take a little bit of a break, but we should get you in there. I was going to say we should get you in there if you want to be in there, right? But if you don't want to be in there, should you still have to go to PE? What do you think? Yeah, you should. He should go to PE. Okay. Yeah, probably a good idea. Because we don't let you get out of math. You know. Cool. All right, enough. Let's keep going. Okay, this is another question. Does CRMO put me at increased risk for broken bones? I have CRMO. I have something wrong. Am I going to be okay? Can I do all the stuff I'm supposed to do? For the spine, what is the spine? The spine's the backbone, this thing. Right there. That's your spine. If you're in good control, you have well treated, you'd think it's going to make it weaker, but actually it doesn't. There's a ton of research on vertebral spine fractures, and that is a big concern if not being treated effectively. But for good treatment, the spine actually does great. But if you have active lesions, things are going on, we're going to try to back you down a little bit. We're going to say no contact sports, no big jumping and running and pounding stuff until you're doing better, all right? Okay, for extremities. What are extremities? For me, extremity means arm and leg. Extremity fractures, it's unknown. We don't know. But that's actually really good. And the reason I say that is because I see kids with CRMO. Dan sees tons of kids with CRMO. It's not like everybody we see with CRMO. Dan says, oh man, you got to be careful because if you fall, you're going to hurt your arm. I want you to feel good about being active because it's not like anecdotally. By history, we see lots of these, okay? Dan, is that right? Okay, good. I'm going to break this down into two different things. Hopefully this is simple, and I don't want it to be insulting, but I hope this makes sense. So types, bones and soft tissues. So bones are the hard parts in things. Everything else is soft tissue. There's skin. Right underneath your skin, there's something called subcutaneous tissue, which is really big, kind of fat. Okay. Muscles, tendons. Tendons connect muscles to bones and move things around. And ligaments. Ligaments connect bone to bone and keep things stable. Okay. And then timing. Acute versus non-acute. So if I land and I fall, hurts, that's acute. If I decide I'm going to try to train for something and I run for 3 weeks or so and my knee starts to hurt, but I didn't fall on it, I'd consider that more non-acute. Something's kind of built up, okay? So acute, non-acute, bones or soft tissues. Let's go over acute injuries. Acute bony injury. Fracture versus broken bone. Was it really a broken bone? Is it just a fracture? To people like me, broken bone and fracture mean the same things, okay? And this is one of the bigger teaching points for the adults in the room that we're talking about. So if you're concerned about an acute bony injury, I fall on it and it hurts, you guys know that MRI is the best test for everything because most of you guys have had a total body MRI. This is weird, but if you're going to worry about a fracture, X-rays are the best test for us. They're actually better than MRI. Do you remember about 1,000 years ago, people used to have to buy something called a digital camera before we all had phones? They used to talk about, a megapixel thing. One of the radiologists once told me that if you take a plain old single X-ray like that, versus an MRI, the pixel quality, the ability to see, is actually way better on a plain old x-ray to look at the bone. So we're going to get x-rays first. It's actually better for this indication. We'll talk about MRIs for the other stuff later. Acute soft tissue injuries, bones, bruises, which you know about, sprains, muscle strains. Okay, and we can talk about that. This is the one thing I want to talk about that might be useful, might be kind of stupid. How to tell soft tissue injuries from fractures at home. This is what I talked about for if I talk to a group of docs that don't have x-ray right at their capability. How do you tell? So suppose, boom, I land on my arm, ow, and I come in and I go, oh, this hurts, it hurts really bad, and I've got a big bruise right there. How do I know it's a fracture or not? Because if I touch right there, it's going to hurt right on the bone, right? But I can do something in medical terms called axial load or rotatory stress. If I take this bone and it's broken right here and I push on it or I twist it, it's going to hurt still. Actually, it's going to hurt a lot. But if it's a bruise, probably doesn't hurt too much to push on or twist it. Now, for you adults, you might not want to push and twist on your kid's bone if it's broken, or you might, not mean, but you can figure out a lot of information from that. That makes sense? All right. Any questions on that one? Yeah, don't give it a try like for fun, but if you can learn a lot from trying that. All right, non-acute injuries. Stress fracture, acute bony injury. Like I've been trying to get ready for some kind of a race, and I didn't exercise. I tried to run 10 miles a day for 2 weeks, and it hurts on the bottom of my foot. You could have a stress fracture, stress reaction. It's not a bone that's been broken in half, but it's a bone that's got a weak spot in it. Here's the problem with that. X-rays do not show stress fractures very well. They can show them, but they could be negative, could be positive. If you come to see me and you've got a stress-related injury, I'm going to get an x-ray. I'm not sure what it's going to show. But if I'm not sure, and I really want to be sure, what test would I probably get to figure out if the bone is fractured the stress fracture way? Because the x-ray looks good, but inside, is there a weak spot? I would actually probably get something, the MRI, which you guys all know about. Here's the tough part. Here's the stinky part about this. Stress reactions of bone and chromo are very hard to tell apart in MRI. So like if you said, how am I going to figure out which one this is? Dan's going to say, I can't tell because it looks the same pretty much. So what do? We're probably going to try to rest the bone. Just give you rest. Sorry about that. Take a couple weeks. And if it's chromo that's active, it's still going to hurt. If it's a stress fracture, you're going to start to feel better and better and better. So tough one, but that's what we try to do. Okay? Non-acute soft tissue injury, tendinitis, tendinopathy, and then, MRIs are great tests, but they're hard to tell apart. So how can you tell a non-acute soft tissue injury from a bony injury? Bony injuries, will often hurt to put weight on them. They'll hurt to press over the bone, just like a fracture, but they'll hurt. If you have a tendon injury, it hurts to use it. So I don't have to put a lot of weight on this, but if I bring my foot, if there's a tendon injury here, or tennis elbow, and I lift this up, and I push against it, that's going to hurt. Probably won't hurt the bone as much unless I'm pushing right on the bone. Does that make sense? Using the tendon, using the muscle, is going to hurt if it's a muscular injury. More loading that bone or pressing on the bone is probably going to hurt if it's a bony injury. Okay, all right. Summary. Activity is good for all bones. Chromo should not exclude a human being from any type of physical activity, sports participation. X-rays are the best imaging type for acute fractures, acute bony injuries. I want to see if there's a fracture there or not. And rest is very helpful to distinguish between non-acute injuries because MRIs aren't as helpful. And yeah, hopefully that's helpful, wasn't too painful. All right, any questions for me? How am I doing for time? Good. Oh, thanks you guys. Yes, go ahead, sir.
So, for extremity injuries, what with chromo? Would a brace, wrapping it with tape, does that help prevent anything? Is that recommended?
Let me repeat the question. So for chromo or a lower extremity kind of a chronic injury, is that what you said?
No,
Or
with
any
kids,
injury.
like my son, if he wants to go play basketball, and should we wrap his ankle? Because just to help prevent any type of, as prevention, to prevent any further injuries to a joint or a bone or anything like that.
Okay, thank you for the clarification. So you got a healthy kid without any injury, but he has chromo. Should I wrap his ankle to try to prevent an injury?
Correct.
If his bone is healthy and well, I don't think you would have to do that. I don't think it's going to prevent injury. If you said, boy, when I wear this brace, I feel better, I feel more stable, I think that's fine. The big thing we don't want to do in sports anyway is have somebody who says, this feels a little weak, it's not quite there, let's put a brace on it and go do stuff, because I think we'd rather have you using it, getting it stronger, getting your balance and strength there. But if you have a healthy ankle and it feels better to use it, you can. Tons of high schools, like the whole team, girls volleyball, will wear all ankle braces. And that's just kind of almost like a culture for them. Wait, I want to make sure, did that answer your question? Yes. Okay, thank you. Great question.
Yeah, just to add on to that, I think there are several scenarios. One is you have a lesion before, and now it's better, you're worried. And it also depends on your conditioning. If you haven't been playing for 3 months, your muscle is going to be weak. Your tendon needs to be stretched. So the best guidance will be working with a physical therapist, and they can guide you whether you should or should not, and start with slow, gradually. So we call it sports rehabilitation. But if you have active lesion, depends on what MRI looks like and how severe symptom is, and wearing some supporting device will help, right? And also you need to take into consideration how intense you can play. So these are just some things. But if you have an arm lesion, but you're worried about the ankle, then I totally agree with what Dr. Jinguji has said.
Anything I say, anything Dan says, listen to him, all right? Serious. Ask my wife, she would say the same. Guys, anything else? And I'll be around till lunch too, so. Go ahead, sir.
On one of your slides, you mentioned chromo, waning, and waxing. What is that?
Oh, I'm sorry. Maybe I didn't use the right term. I just think it goes through phase. Like it can get better, can get worse. And if you can have somebody that just says, I'm having a rough day. Can I take some time? Can I just understand that? Did that answer your question? Okay, thank you. Good question. Yes.
Sorry, we have a question from the chat. Someone says, my son has chromo in his jaw area, but he needs braces. How do I know if it's chromo pain or pain from his braces?
Oh man, let me. So this is thinking off the top of my head. Let me think about how I would answer that. Well, if it's a bone type pain, and it just goes away in a day or two with the bracing, which would be standard, I would feel pretty good about that. I think I would love to talk with that guy, the dad or mom individually, because if it's always there, I'd be more concerned. Dan, do you have chromo brace pain?
So it's very difficult, and I think a lot of times we have to talk whether this is the right time to install the brace or not, because it's going to interfere the MRI, so we won't be able to have an accurate read. So a lot of times we ask them to delay until we have a good control of the CRMO. And once we are gaining good control, and we need to commit to that treatment probably for a couple of years during the bracing, and just knowing that we won't be able to take it off and get a scan and put it back on, that's too much of a hassle, and just get it done. So in my personal experiences, if we find the right medication, we keep the patient on the same medication, rarely the bracing will cause a flare. So I would bet most of these times it is the pain caused by the brace. So just more biological kind of deduction rather than really anything else concrete. Another thing I'll say, the flare often will be associated with some swelling, warmth on the jaw, in the face bone here, that some of you as parents, you remember nodding. So that is another way for us to confirm, and where the dental brace, the pain will be more from the inside.
Thank you, Dan. Much better answer. All right, I should oh, go ahead.
Why or how does like the common cold or flu cause a flare-up?
Why does a cold or flu cause a flare of chromo?
Yeah.
Thank you for the question, and I apologize for deferring, but yeah, good question.
So that may happen. I think we haven't studied that particularly, but based on the research on other rheumatic diseases such as arthritis, and we noticed that could be the case. One thought is when you're fighting off a germ, your immune system needs to be activated. And this disease is caused by a dysfunctional immune system. So the stronger your immune system is on fighting other things, and it may spill over and fight off, just like you have a fire in the house, you're trying to put off the fire, you're going to have some water damage. But once the immune system settles down, the infection is gone, it's supposed to recover, but sometimes it still lingers around. That's one of the theory. And one of the things we want to be sure, of course, if the patient is on medication, stable, we haven't found the small infection as going to cause a flare. But often because you have to hold your medication for a week or two until get better, and that may potentially cause the delay of delivery of the medicine to the site, right? But if you're off medication, and that is a theory, so we probably need to test that in the future.
Thank you guys so much for your attention and your time. I'll be here at the break, and I'll be here probably till about noon, so I would love to talk with any of you that are interested.
Yeah. Thank you, Tom.
You're welcome.
Let's give Dr. Jinguji another round of applause. I appreciate it. That's really helpful. Emily Shield is one of our fellow who is going to study how patients are able to take their medications on time, and what are the tools that you can leverage with all the modern technology and other available things. So she has got IRB approval, and she has recorded its video and their things generated. The study is looking for patients who are currently taking medications either by pills or injections, and she will reach out to the eligible patients and to the consent, and we'll do several surveys. That's how the study is designed. So if you're interested in, please email crmoresearch@seattleChildren's.org with your child's name and date of birth and best number to reach you. And Dr. Farzana Nurzaman is one of the pediatric rheumatologists from Stony Brook. So we work together to generate the MRI scoring website. And this can be an education tool for the radiologists and rheumatologists worldwide. In some of the places they don't see as many patients, they can use that atlas and to know in each bone if it is affected by CNO what it looks like. And also they can record their reading and check with the experts readings from Dr. Ramesh from Ayer from here, Dr. Sean Settle from Iowa, Jennifer Stemek from Sick Kids. So she's gonna introduce that tool to you.
So I may be preaching to the choir, but I just want to go over what CNO is. We know that CNO is a chronic inflammatory bone disorder. It can cause bone pain and bone destruction. And as a chronic disease, it also affects the quality of life of patients and families. However, we still have lots of questions about CNO. We don't know exactly what causes it. We don't know the best treatment for each individual person. And we don't always know the long-term outcomes for patients with CNO. And so it's hard to tell if the disease is active. How do we know whether a treatment is working or not working? And so some of these questions can only be answered by more research studies, including quality clinical trials to compare one group of patients with another. But we need to be able to measure these outcomes in a way that's not subject to bias. So that's what got me interested in this research project and that I'm going to show you today. But one important way that pediatric rheumatologists see if there's inflammation in the bone that may mean that the CNO is active is through the use of MRI, or magnetic resonance imaging. MRIs are a good way of checking how bones have inflammation or not because they don't require the use of radiation. And MRIs are also more sensitive than other imaging methods to see CNO lesions. However, sometimes when MRIs are read by radiologists, it depends on who's reading the MRI. And some radiologists may not be super familiar with CNO or the imaging findings associated with it. So we wanted to be able to measure what radiologists see on MRI in a way that's objective. So several years ago, Dr. Zhao, along with several other radiologists, created a standardized scoring system to assess specific characteristics of the bone and the soft tissue, as well as skeletal damage. This is called CROMIS, C-R-O-M-R-I-S, or CRMO MRI scoring tool. Dr. Zhao previously published work that showed that this scoring system showed sensitivity to change after patients were treated aggressively in a retrospective cohort study. They also showed that these scoring system was able to achieve similar scores between readers to show reliability. However, that system was paper-based and was pretty hard to use. So my project was to develop an online system in which we could score MRI studies of children with CNO. And we were able to complete this project with partnership with Care Arthritis, a nonprofit research organization based in Canada, who has had development in experience in developing MRI scoring tools in other conditions like spondyloarthritis. And we also used the help of our wonderful group artist, Lauren Potts, radiologists, and with funds from the Care Arthritis Foundation to complete this work. So now just give me a few minutes to share my screen so I could actually show you what this website looks like. Now, as you can see, this is the website. It's housed under carearthritis.com/MRI portal/CRMO/index. And there will be a barcode so that way you can scan the QR code at the end to access this website. Anyone can create an account on Care Arthritis website. And once you log in, you're able to see the Care Arthritis website. And there are different features that I wanted to present in relation to the CRMO module. First of all, we have the way that we score the system is presented in the CROMIS Atlas, which was created. And basically, this goes through several areas and information about how to score. What is the recommended whole body MRI protocol? So like how should institutions have MRIs, what imaging sections they should order, and how it looks up as a stitched. And then I go through the different scoring regions that you'll see on the website. The different parts of the body is separated into different regions. And it also gives helpful tips and tricks about how to do the scoring, which you can read through. So now going back to the home, there's also a useful tutorial video that I've been looking for product that Dr. Sean Sato recorded after this ad. You can watch that. And then going back, we'll go into the actual CRMO case. So this is a system that you could create. So you go on to review and score images. And basically, you'll see over here, as I expand my screen, that there are several tabs. So on your right side, you'll see the tab with the lovely images and illustrations, schematic diagrams that are very clickable and easy to click. And then within each section of the bone body, there are different sections. So we start from the head, going down into the torso, going into the upper extremities, the hands, then spine, then pelvis, then legs, and then feet. And then you'll see that each part of scoring, you'll see the images here for your study. And these are de-identified images that we have for practice of patients with CNO. And within each scoring, so let's say that we go into the legs, and we want to say that we're looking into, let's say, the spine, actually, because we have a nice image over here. And then you'll go into the spine, and then you'll look through the spine, and you'll try to see if there's any lesions that you think are compatible with CNO. So that's the bone marrow hyperintensity, and here's a quick little key. And then you could click, and then you're able to see a score on a score of 1 to 3, how big that lesion is. And additionally, we score on how much inflammation there is on the soft tissue and whether the lesion affects the bone, surrounding bone, so bony expansion, and particularly for the spine, if there's any spinal compressions. And then after you're done scoring, you can press submit, and we get a summary score along with a full schematic of the full skeleton. And based on where you clicked, you'll see where the lesions were. And you can see the different tab regions of the body, and then the different components of the score. And then we get what's called a Chromis Activity Index on the radiology basis. And that's how you go to score a case. And you could move on to the next case simply by going to next case. You could go to the next case without completing. You could complete and go on to the next case or return. So these are just some areas that's been developed for the use of scoring MRI scoring system. And I think what's helpful is that all of these data can be used to score images between patients and see whether the disease is getting better with treatment. So that might help in determining what type of treatment is best for each individual patient, and really assess whether they have active disease that may require changes in treatment. So I'm going to stop sharing. And so hopefully that was just a quick rundown of this CRMO module scoring system that we hope to share with you all. And so you could create your own accounts and try to look at these practice lesions and inform your own radiologists and pediatric rheumatologists. Thank you.
It is intended for the doctors, but I think nowadays everybody Google everything anyway, right? So I think there is democracy in that. It's available to public, anyone can use it. So I do see during the clinical visits, and a lot of patients can just point out, oh, that I give them the general idea, what is normal, what is not normal, and I ask them. And most people are able to identify where the problem is. So it's not a bad idea for you to start because you can request all the MRI images yourself as well. So it should be available. I believe that's the principle for all the hospitals. Is another question?
He actually asked part one. She said it was rated from 0 to 3. How do those work? Those lesions?
Yes, the numbers, the numbers. So if you don't pick anything as a 0, that means there's no lesion. And then if you check any spot, so by default, there will be at least level 1. So we define from 1 to 3 as the percentage of the bones that were inflamed. And it gives us a way to assess the difference because the lesion may not be gone just after 3 months of treatment, but it changed from 75% to 20%. That is improvement. So that level is to address that. And then for the other parameters later on, you see a couple of other boxes. These are just yes or no. So one of them is the soft tissue inflammation, and then the bone expansion. So is the bone much larger than it was before? And that will take more long-term data for us to know if any of these are reversible. We know the soft tissue inflammation is reversible. We know the vertebrae compression fracture is not reversible. So that's why it's going to be counted as damage instead of the active disease, because giving further medication, if there's no inflammation, is not going to help. Yeah, that's a great question. Any other questions?
So the grading system is like a strained muscle, grade 1 through 3, kind of similar to like a pulled muscle, grade 1 versus a grade 3. They're just how much damage is
It's
done.
by percentage, so 25%, 50% or more, yes.
And then I think, sorry if anyone else has another question. I think she said that it spits out a number at the end.
The what?
There's like a grading system at the end of.
Oh, yes, the total. So let me go back to the, I can use my slide and to show. Is this what you're referring to? Yeah. Okay, great. And everybody can take out your phone. There is a QR code, so that will lead you to a website. This is really one of the essence of this report as well, that right now it's only programmed as you're matching the reporting on the given set of images deposited in there. But we are talking to care arthritis and to see if they are allow the radiologist to just generate a count, and they can use this tool with their local image. So they can have two screens. One screen is their own patient. Because of the HIPAA, everything, they can't just freely upload those to the website. But then they can have this as a reporting. They'll put in all the where the places are, and then at the end it will give them this. They can use a screenshot and incorporate into the report. So this not only is visual, where is inflamed is right there labeled, and you have a general idea, but also give you detailed score over here as well, and then give you the damage that's on the last column. I think this will be a really helpful tool just for all the radiologists and even rheumatologists. Yeah. Maina, well, do you mind? Maybe you can go.
So really just, I guess, a quick question, Dr. Zhao. So I guess, so my son's an adult now, so I guess his rheumatologist there is going to do a baseline MRI to see what he's like and compare it to his old one. So I guess, is that scoring system strictly from a pediatric perspective, or does it matter if it's adult or pediatric? And I guess for his rheumatologist, is there value in him looking at that scoring to compare the two, the old X-rays from when he was a kid to now?
Yeah. So I don't think that is restricted to just pediatric. The difference is the physis is open, the growth plate in kids, but then the lesion and what you see in adults and the children will be similar. There is some marrow change after you turn a certain age. The signal is a little different, but I think our patients, majority stay until they turn 21, so we have those data to tell what is the just marrow change, what is the true CNO lesion. But radiologists do differ. Even we have 3 world experts already put all their data in. They don't agree 100%. So we have to do a consensus and get them all sit down and agree on it. I think the eventual goal is we can use AI and guide some of those, and with the experts kind of readings, and we use that as the grand truth. So in the future, that will help in the places where they don't have the expert radiologists to read those. And maybe that will save your time and strain your eyes and to read all these. And Maina?
So is this different than a diagnostic tool for somebody coming in not knowing if what they have is CRMO or not?
That is a whole different question. So we're talking about this tool strictly for patients already diagnosed.
Great.
When we're talking about whether it is helping you to diagnose, we don't know what this is. Is this CRMO? We cannot use this tool.
Got
so
it.
I'll touch base on that in my research update.
Perfect.
Great question.
Thank you.
Thank you for clarifying. Okay, so for the sake of time, we're gonna go back to the beginning of the slides, and so I just want to give thanks to our Seattle Children's Research Team and also our sponsors as well for the research, and also the CRMO research group, also several of the patients and parents. So four areas I want to touch base on. One is the update on the American College of Rheumatology. That's our professional society here, but also European counterpart, EULAR. They sponsored this classification criteria for pediatric CRMO. And then a validation of a clinical disease activity that is not depending on MRI alone. And then the patient-reported outcome that many of you have completed these questionnaires every visit, and what did we learn from that? So you're going to get a glimpse of that. And the imaging portal you already watched. So what is the classification criteria? So this is not for clinical use for you to make a diagnosis, but it's more for the researchers. When you recruit patients into your research study, you want a more homogeneous group. That means they don't differ a lot from each other. Because this is already a rare disease, they may have a different process. And then you don't have enough patients in your study, then you see nothing. You don't have any findings. So first you want to start with a more tight group. And then you find something, and then you're going to start the other group. And how different is the other group within the same diagnosis into this, right? And we also need an international consensus. So it took 7 years, but we're almost done. I hope it will be published within the coming month. From the time it was conceived, and it involved many of the colleagues worldwide, and depositing the data on not only the patients from CRMO, but also those who look like CRMO, but they were not. And so we can compare the apples to oranges. And what are the features of apples? What are features of oranges? And that can help us. And of course, COVID got in the way and make things a little bit more challenging, but we persevered. So this is I can tell you the case report form includes 140 variables. There are a lot of information we collected. We didn't ask every institution to give us the images, but we did ask which area of the body that has been confirmed by imaging, or what patients have complained. And thanks to Lauren Potts, who have drawn the illustration. And as you can see, that's almost 50 sites from 5 continents. We had majority of patients were CRMO, probably 600 or so, and the other 300 or so were patients with mimicry diseases. And many colleagues across the ocean dedicated their weekends in having these meetings over the last 2 years. And also we have Lauren and Alex from the patient-parent group, and also our own Leslie Vogel, our physical therapist, join us as well. And Cesar Olsen is our leader from the European side. I was the leader for the American side. So we defined the terms, and then we have to argue with each other. And why do you think this is more important than the other? So we were forced to do these comparisons. It was a little bit tough and with a lot of heated discussion, but I think in the end, everybody was happy with what we have got. And then we have to set a threshold. When you use that criteria, what point you will say there's more likelihood that this is towards the CNO. So if you think you're going through the pipeline, and there are different crossroads in which direction you go, so you have to first, what at the beginning will allow you to even think about it? That's the entry criteria. And what is clearly steering you away from this condition? That will be exclusion criteria. And then you have these things that can happen in CRMO and mimicker, but it's more likely to be CNO. Then you need a bunch of those and add it together, and then you are feeling more confident it is. So I won't go through all the details, but there are all the terms in entry criteria, what needs to be. It's similar to some of the criteria for chronic arthritis. And then we'll have exclusion criteria, mostly rule out vitamin C deficiency, the infection or cancer. And there are 9 domains of those. So that tells at least the researchers and clinicians you need to get all these information. Most of these are not difficult to get. A lot of times people just didn't think about it, such as the whole body MRI or the ESR CRP, the labs. Bone biopsy is not needed for everybody. So it's in there, but this is not necessary. So we also validated. We have half of the cases used for development of that domain and that list, and also the threshold, and we used the other half to verify our results. The results showed the criteria is 98% specific and 80% sensitive. That means 4 out of 5 times we'll be able to pick or identify a patient with CNO, and once we identify that, it's almost certain that patient is. So, move on to the clinical disease activity, in short, CDAS. So that happens during one of the virtual conference of CARA annual conference. And of course, there are a lot of prep work before that. And the MRI data and clinical symptoms are not always correlating. That caused a lot of dilemma, tough decision making. And also for clinical trial, how FDA is going to prove it, that they are not going to use the MRI data alone to say, well, you should approve this medication or not. You have to come down to the patient's complaints and their functional analysis. So that's why we need to have an MRI independent scoring system. And 3 items surface to the top. One is the pain scale. The other is your global assessment of disease activity. That means how much does the active CNO causing inconvenience in your family that make you hard to do things that you normally should be able to do. And also from the physician's exam, how many spots, as we're talking about the face bone, right, or ankle, how many spots just from the exam you're able to identify that it looks inflamed. And using pain alone is not reliable. As we all know, there are many confounding factors, but when you add all these 3 together, it behaves beautifully. So we have validated that it was published, and also we deposit the whole paper into free access. If you just Google it by the title, it's called MediaRex, and it's all available. I believe we have put in the Inside Out Care as well. So that tool is available for us to do many more studies. And the question we can ask are the current treatments, which one is more effective than the other? Or more effective in certain patients than the other treatments? Or what is the long-term harm of some medications? And because we also have concerns about that. And so far we have enrolled more than 420 patients across 15 sites, and 8 are based in the United States and 7 were international. We have submitted several grants to NIH and PCORI. Hopefully, we'll be able to get more support to expand it even more. And we published the first paper. The second paper on the patient-reported outcome is coming. And Tuan Bui and Gabe Kesselman were former students and who have put a lot more work into how to score all these questionnaires. And Dr. Xing Wang was our statistician. And so you all have seen this before, and you know how painful it may be at times or easy it is. So it depends on whether you're on a flare or you're doing well. It can be fast, but sometimes can be lengthy. So this is really crowded slides. I apologize, it's hard to see, but the basic idea here is on the x-axis of each panel, it tells you what patients think that they were having active disease or not, or severe disease or not. So from the left, that will be completely well to mildly active to moderate to severe. So what you want to see is on the y-axis is when they're reporting more severe disease, then the dots are going kind of more towards on the upper. So the first left upper corner, it shows what physician is thinking. So it correlates really well, not surprisingly, right? We have to listen to your concerns. But the other are from the questionnaires. A few of them standing out. One of them is mobility. It tells us how well you move. And then the other two are pain. One is the behavior, what you do if you're in pain, and pain interference. What can't you do when you're in pain? So the results are not surprising that the two pain forms behave similarly. So that means we probably can drop one of these. So save a little bit of time for everyone. And the other thing is that fatigue also shows a good correlation there. But fatigue, it does not behave or follow that trend as well. I think it does measure different components, and you could continue to have fatigue even though you don't have active disease, but just because you have been deconditioned for a long time, or you don't feel like doing things, or there could be a mental health component as well. Physical activity, very surprised that it didn't correlate, and why? It could be you think you can still do, but you don't do it at the same intensity. Now the strength also correlates a little bit, but not to the this extent, and it could be the questionnaire itself is not sensitive enough. So in the end, I think mobility and the pain and upper extremity, I want to point out that only minority of patients have upper extremity, so that needs to be further studied. So I don't think we should throw that out yet. And we also need to consider the mental health questionnaires in the future. So I think we already talked about the MRI. That was the group, and Frazan, I already talked about that. So that's the end of my report. Back to you, and they'll be happy to answer any questions. Oh, sorry, for the MRI. Let me open that again, sorry. Is this the one? Maybe we can talk offline. Yeah, so, okay. Great. Now I'll turn it back to, is there another question? Yeah.
Sorry, thanks. Do you ever plan to include any holistic treatments in the studies, like even biofeedback, like pain management, mental health, mind-body stuff, and nutrition or supplements? Because I know a lot of a lot of families kind of integrate that stuff, but that's not necessarily documented. So I'm just wondering if something like that is in the works for in the studies.
Yes. So the question is, do we have any plan to study the alternative medicine and the mind-body, the holistic method? We did talk about complementary medicine at last conference, so please refer to that recording. And I think that is a very important field and area. And one of the challenge at the current moment is the funding, right? And second is enough of patients who are willing to go through that. I think it just needs thoughtful design and have the safeguard rail and then when to exit that trial if we're going to do it, so we don't harm the patients when it doesn't, similar to the drug trial as well. So I absolutely agree with what you say. Yeah. Well, thank you, everyone.